Clinical reasoning in internal medicine. Clinical approach to MI. Pathophysiology. Acute coronary syndromes, which exist on a continuum ranging from unstable angina pectoris to NSTEMIA to STEMIA, usually are caused by in situ thrombosis at the site of a ruptured atherosclerotic plaque in a coronary artery. Occasionally, they are caused by embolic occlusion, coronary vasospasm, vasculitis, aortic root or coronary artery dissection, or cocaine use, which promotes both vasospasm and thrombosis. The resultant clinical syndrome is related to both the degree of atherosclerotic stenosis in the artery and to the duration and extent of sudden thrombotic occlusion of the artery. If the occlusion is incomplete or if the thrombus undergoes spontaneous lysis, unstable angina occurs. If the occlusion is complete and remains for more than 30 minutes, infarction occurs. In contrast, the mechanism of chronic stable angina usually is a flow-limiting stenosis caused by atherosclerotic plaque that causes ischemia during exercise without acute thrombosis. Table 1.1. Table 1.1 Clinical manifestations of coronary artery disease. The pain often is accompanied by sweating, nausea, vomiting, and/or the sense of impending doom. In a patient older than 70 years or who is diabetic, an acute MI may be painless or associated with only vague discomfort, but it may be heralded by the sudden onset of dyspnea, pulmonary edema, or ventricular arrhythmias. Physical findings. There are no specific physical findings in a patient with an acute MI. Many patients are anxious and diaphoretic. Cardiac auscultation may reveal an S4 gallop, reflecting myocardial noncompliance because of ischemia, an S3 gallop, representing severe systolic dysfunction, or a new apical systolic murmur of mitral regurgitation caused by ischemic papillary muscle dysfunction. Electrocardiogram. The ECG often is critical in diagnosing acute MI and guiding therapy. A series of ECG changes reflect the evolution of the infarction. Figure 1.2. 1. The earliest changes are tall, positive, hyperacute T waves in the ischemic vascular territory. 2. This is followed by elevation of the ST segment myocardial injury pattern. 3. Over hours to days, T wave inversion frequently develops. 4. Finally, diminished R wave amplitude or Q waves occur, representing significant myocardial necrosis and replacement by scar tissue, and they are what one seeks to prevent in treating the acute MI. Figure 1.3. Figure 1.2. Temporal evolution of ECG changes in acute myocardial infarction. Note tall hyperacute T waves and loss of R wave amplitude, followed by ST segment elevation, T wave inversion, and development of Q waves. Persistent ST segment elevation suggests left ventricular aneurysm. Figure 1.3. Subendocardial infarction produces an inward ST vector, resulting in ST segment depression. Transmural infarction produces an outward ST vector, resulting in ST segment elevation in the overlying leads. Sometimes when acute ischemia is limited to the subendocardium, ST segment depression, rather than ST segment elevation, develops. ST segment elevation is typical of acute transmural ischemia, that is, a greater degree of myocardial involvement than in NSTEMI. From the ECG we can localize the ischemia related to a vascular territory supplied by one of the three major coronary arteries. STEMI is defined as ST segment elevation more than 0.1 mV in two or more contiguous leads, i.e., in the same vascular territory, and/or new left bundle branch block, LBBB, which obscures usual ST segment analysis. As a general rule, leads 2, 3, AVF correspond to the inferior surface of the heart supplied by the right coronary artery (RCA). Leads V2 to V4 correspond to the anterior surface supplied by the left anterior descending coronary artery (LAD), and leads 1, AVL, V5 and V6 correspond to the lateral surface supplied by the left circumflex coronary artery (LCX).